Thank you so much for kindly having me. I'm happy to speak about menin inhibition and ziftomenib. Unfortunately, I cannot talk about any upcoming data to be presented at EHA, given the fact that it is embargoed, and we will find out about it hopefully in a few days. However, I can speak broadly about ziftomenib and what's already been published. As you're probably aware, and your audience is probably aware, ziftomenib is a menin inhibitor. Basically, it interrupts the interaction of menin with a key complex. A key protein is KMT2A, so it interferes with that interaction of menin and KMT2A, and in that way, through the mechanism of allowing a release in the block of differentiation, allows abnormally aberrant myeloid blasts to begin differentiating more normally, leading to a differentiation response and hopefully normalization of blood counts and a response in patients who have acute leukemia. The subgroups of patients that seem to respond best preclinically and in some of the emerging clinical trial data are those individuals with KMT2A rearrangements, which are common alterations seen in some disease subtypes, as well as those with NPM1 mutations. The altered NPM1 protein interacts with the KMT2A menin complex, and in that way likely promotes differentiation block and AML phenotype. So these drugs also work quite well in that subset of AML too. At ASH this past year, we presented data in the phase 1A, as well as some of the patients in the phase 1B group for both KMT2A and NPM1 mutated AML. In general, we found that the drug was quite well tolerated in the sense that there was not much hematologic toxicity. Patients with KMT2A alterations had a higher proportion of development of differentiation syndrome, some of which could be quite severe. It was less common in NPM1 mutations. With patients with NPM1 mutations, and the rates of response actually in our group was higher in patients with NPM1 mutations as well. We in the phase 1B portion of the study, instead of looking at multiple dose levels and dose finding that was done in the phase 1A, we looked at only two dose levels, 200 milligrams and 600 milligrams in patients with NPM1 mutations and KMT2A alterations. And at least at the 600 milligram cohort, we found a very nice overall composite remission rate that was around 33%. And the overall response rate was around 41%. So this data will, specifically the NPM1 mutated data, will be updated at the upcoming EHA meeting, and I look forward to presenting that data. So it is a very exciting class of drug for AML, and we shall see if it has a role in the future in this disease.